Thank you, Rochelle, and welcome to everybody, both who are here live and on Zoom. I am so excited about this presentation today by three GloCal Fellows from St. John's Medical College and Research Institute in Bangalore, India. I have had the pleasure of mentoring for the past almost 1 year now. And they've been working really hard on their GloCal studies all year and are excited to come here and share a little bit about what they've been going through and their results so far. They are here now for about a 2-3 month visit, both to network with other researchers who may share their interests, to learn a little bit more about how researchers at UCSF and Berkeley work on similar problems with similar populations, and also, and probably most importantly, to get some protected time to write up manuscripts and start thinking about next steps in terms of grants post-GloCal. So without further ado, I'd like to introduce our first speaker, presenter, Dr. Merlyn Joseph, who will be talking to you about mental health status of migrant workers in the tea plantation industry of South India.
Thank you, Dr. Ekstrand. Good morning to everyone who is here live as well as online. I'm Dr. Merlyn Joseph. I'm a faculty at the Department of Community Health at St. John's Medical College, Bangalore, and I'm also part of the Division of Occupational Health. My GloCal study is on the mental health status of migrant workers in the tea plantation industry of South India. It's a mixed method study. Now, the plantation sector in India is one of the largest private sectors, and it employs close to 2 million population. And tea, coffee, as well as rubber are the main plantation crops in India. And it is a very family-based employment where the worker with his family lives in the tea garden, and he works and lives there, and he's provided with facilities like housing, healthcare, and other welfare measures within the plantation. There are different types of works which occurs in the plantation. It could be tea plucking, for which women are most commonly employed because they have nimble fingers and small hands, and pesticide spraying, for which men are commonly employed, and also factory work. Now, where is tea grown in India? In India, tea is mostly grown in the northeastern states of Assam and Tripura, as well as in southern states of Tamil Nadu, Karnataka, and Kerala. Now, the tea industry is currently going through a severe labor shortage crisis, and that is because the offsprings of the tea workers are educated and do not want to come back and work in the tea gardens. And so there is a lot of internal migration happening from the north of India to the south. And the pull factor for the migration is basically better pay and working conditions in the south of India. Now, considering all this, we found that there is a lot of socioeconomic and cultural factors or issues which is brewing in the tea industry. Factors such as poor wages, or even socioeconomic, they are geographically isolated, they don't have proper health facilities, and there are lack of recreational facilities. And all this can have an effect upon the mental health status of the workers. But mental health as such is not a component of the Plantations Labor Act. And while there has been a lot of discussion about the cross-country migration and the international migrations, not much has been discussed about the internal migration which happens in the country. And keeping all this in mind, we wanted to study about what is the prevalence of common mental health disorders and determine what is the difference between the migrant and the local worker population in the plantations. We also wanted to assess what is the barriers to access mental health care here, and also understand what is the mental health how is the mental health status, their barriers and facilitators, as well as the unmet mental health needs of the migrant workers in the tea plantation. Now, for context, I am in Bangalore, and my team traveled all across the southern states of Tamil Nadu and Karnataka, and it was ranging between 5 hours of travel to 11 hours of travel one way. Now, for the first aim, that is first and the second aim, which we conducted a cross-sectional study, We chose almost 70 estates which had a large migrant workforce in them, and our sample size was 377. We undertook a multi-stage stratified random sampling where we stratified according to the estate as well as according to whether the worker was local versus migrant, and included all the workers who were working for at least 6 months in the study. And my main tools included a socio-demographic profile, questions on their occupation and migration history, the self-reported morbidity profile. To assess for their alcohol use disorder, I use the audit tool. To screen for depression and anxiety, I use the PHQ-9 as well as the general anxiety disorders 7 scales. I also developed scales to assess the knowledge regarding mental illness, which is scored from 0 to 11, as well as the barriers regarding barriers to seeking mental health care, which was scored from 0 to 33. Now, I collected the data using EpiCollect 5, which is a web-based data gathering app, and this is how the app looks. And data analysis was done on Excel as well as SPSS. My main outcome variable was the prevalence of mental health disorders, that was depression, anxiety, as well as alcohol use disorder. And also the second outcome was what are the barriers to seeking mental health care. It was on a score of 0 to, ranging from 0 to 33. I used tests of significance like chi-square test and Mann-Whitney-U, and also Poisson regression for the count variables. Coming to the results, my participant profile is as follows. The median age of the population was around 42 years, and we can see a clear difference between the local and the migrant workers. The local workers were older, 51, and migrant were 26. There were around 32% male and 68% female population, and it was roughly coinciding with the general gender distribution in the plantations. The median years of schooling was around 7 years. And again, there is a difference between the local and the migrant workers, where the migrant workers had more years of schooling as compared to the local workers. And then the employment status, we had around roughly 50% were temporary workers and 48.9% were permanent. Coming to the median monthly household income, we had around a household income of $180. And we can see that the local workers, the household income was lower than that of the migrant worker. And this might be because the migrant worker comes as a family and the family as a whole works, whereas usually in the local settings, it is just one person working. And the morbidity profile, we found that 50% of our population did not have any morbidity, while 48.7 had some form of morbidity, and it was more seen among the local workers who had common morbidities like musculoskeletal disorders, migraines, diabetes, and hypertension. Yeah. So coming to the prevalence of common mental health disorders, firstly, depression. We saw that around 6% of our population had symptoms of mild depression and onwards. And anxiety, we have found that around 5% of our population had mild anxiety and onwards. And alcohol use disorder, low risk of alcohol use was found in around 19%. And then hazardous or harmful alcohol consumption was found in 5%. When looking for, when we see the same data across gender, we find so we find that there was a gender difference in anxiety, where the female workers had more mild anxiety, and also alcohol use disorder. It was seen that the migrant workers had were at more risk of having low risk or hazardous harmful risk of using alcohol. And also there was a different gender difference between the alcohol use disorder in males and females. Now, coming to the barriers regarding seeking mental health care, I have not put all the barriers here, but the top 7 barriers as listed is most commonly, they did not know what are the symptoms of mental illness. They did not know what are that there is a mental health expert in the plantation. They stated that there is no mental health expert in the plantation. They also had attitudinal problems, like people do experience greater sadness with increasing age, and that need not require mental health care. And also other barriers like have to travel outside the plantations to seek mental health care, and they don't know what they don't know that mental illness has treatment, Also, they had problems or and attitudinal problems like they cannot work if they are started on medication. And they also had social support barriers like they don't have anyone to accompany them to the hospital. So we see certain differences between the local and the migrant population in that. When the knowledge was scored between 0 and 11, and the total, there was a definite difference between the knowledge of the local worker versus the migrant, where we saw that the scores were higher for the local worker as compared to the migrant. For my aim 3, we did the qualitative study where to understand the mental health problems, barriers, and facilitators. And it was among the stakeholders, such as the estate managers, healthcare providers, and the recent first generation migrants and local worker population. We did a total of 22 interviews with the workers, hygiene masters, estate managers, doctors, and nurses. Now I'm yet to complete my qualitative analysis, but the emerging themes I will be presenting here. So regarding the barriers to seeking mental health care, one theme which is emerging is that there is no treatment for mental health in the plantations. So people have to travel to Coimbatore or Pollachi, which is quite far away from the plantations. Another barrier was the cost of treatment. Most of them are poor, so they don't have money. If a doctor gives us a prescription, how will we buy them? There is also the role of faith healers coming into play, where mental illness can be cured through faith healers, and some people are believing that it's a prevalent practice in the tea gardens. Also, some worries regarding unstable work. So they have fear that if someone finds out, if a supervisor finds out, they won't get work. Also, loss of wages. So, as I told you, there's no mental health expert in the plantation. They have to travel outside. So, it may take 1 or 2 days for the patients to travel, and this can lead to loss of wages. And of course, there is a lot of stigma around mental illness. So, people don't go for treatment in the fear that they will be judged and shamed for. So, in conclusion, my study found that 1 in 10 plantation workers have screened positive for either depression or anxiety. 1 in 4 workers are at risk of alcohol use disorder, and there has been significant differences observed with younger age group, male gender, as well as temporary workers. The top barriers to mental health care seeking was poor knowledge about mental illness and treatment, lack of treatment options, high cost, and fear of job loss. So, my tentative recommendations are, since India already has an acute shortage of psychiatrists and psychologists, it would be prudent to be training the existing healthcare professionals in the WHO mental health gap for early identification and referral of mental health problems. Task sharing and task shifting approaches can be employed among the existing healthcare providers to address this unmet mental health needs. And also policy recommendations, since we have found, and the study has also found that mental health is an important contributor to morbidity. We need to include mental health provisions in the Plantation Labor Act. So finally, I thank all my team members who are there, who helped me collect data. I thank the GloCal for this wonderful opportunity to conduct this study in the plantation. And also I have a huge thankfulness to my mentors, Dr. Maria from UCSF, Dr. Dennis, and Dr. Bobby from St. John's, without whom this study wouldn't be possible. Thank you, everyone.
Right. Well, thank you so much, Merlyn, for a really interesting, thought-provoking presentation. And now we move on to our second GloCal presenter for the day, Dr. Archana Verma, who will be talking to us about understanding cervical cancer stigma, HPV vaccination awareness and acceptance among adolescents and young adults living with HIV in India. And she is hoping that this will contribute to the elimination of cervical cancer by 2030. So welcome.
Thank you, Professor Extrend, and good morning, everyone, both virtual and offline. I am an anthropologist by training, and I am working in the field of social and behavioral research. Today, I'm going to present my GloCal research study, where I explore the knowledge and awareness about cervical cancer and its prevention strategies and willingness towards HPV vaccination among adolescents and young adult population living with HIV in India. So treatment advancements in the field of HIV and easy access to highly active antiretroviral therapy has increased the survival of not only children born with HIV, but also the children and adolescents who acquire HIV through other modes. And therefore, we are seeing the population of adolescents and young adults living with HIV India is the home to the largest youth population with 356 million of adolescents and young adults within the age group of 10 and 24 years. India is also the third largest HIV burdened country with highest population of adolescents and young adults living with HIV in South Asia. This increased survival has brought many challenges, and adolescent and young adults living with HIV faces dual burden of challenges, which can be grouped into adolescent-specific challenges like desire for autonomy, pubertal development, experimentation, involvement in the risky practices, including the sexual behavior, and very HIV-specific challenges like disclosure to the adolescent, lifelong treatment adherence, disclosure to the partner, and psychosocial issues like stigma, discrimination, worries for future. Puberty and sexuality are the crucial component of the adolescence phase, and HIV is not an exception. Adolescents and young adults who are living with HIV are also engaging in the intimate relationships and sexual practices, but in the limited access towards the reproductive and sexual health information and access to RSH services leads to increased risk of secondary transmission of HIV infection to their sexual partner. This also increases the risk of unplanned pregnancies and risk of vertical transmission of HIV infection to the offspring, and increased risk of co-infected with the sexually transmitted infections. One of the highly prevalent infection is infection with human papilloma virus, which is the cause of the cervical cancer. So persistent infection with the high risk oncologic strains of HPV cause the cervical cancer, which is the fourth leading cause of mortality among women across the globe, and it's the second leading cancer among women in India. In 2022, 80,000 deaths were reported among women due to cervical cancer in India. In the presence of HIV, the risk of acquiring HPV infection and progressing it into cervical cancer increased by 6 times. In India, 44% of the total population living with HIV constituted by the women living with HIV, and the studies have shown that there is a high prevalence of HPV and cervical intraepithelial lesions among Indian women living with HIV. Though there is a paucity of research among about the HPV prevalence in the adolescents and young adult population living with HIV in India, but studies conducted in Western countries have shown that there is a high prevalence of HPV and increased risk of cervical cancer among this subset of population. And various risk factors are associated with this, including early sexual debut, unprotected sex, substance abuse, HIV disclosure, adherence to the medication, and lack of reproductive and sexual health information. But cervical cancer is the only preventable and treatable cancer, and the cases of cervical cancer can be nipped in the bud by vaccinating the female adolescents. In India, the HPV vaccine was introduced in 2008, almost more than a decade, but it's still not in the National Immunization Program. The government of India in 2014 recognized the unique needs of adolescent population, and they launched a health program, Rashtriya Kishore Swasthya Karyakram, to provide a holistic services on reproductive and sexual health issues, nutrition, violence, NCTs, mental health, and many more. The HIV program, the National AIDS Control Program, the fifth phase is ongoing in India, which has the provision of linkages with the RKSK to provide the holistic care for the adolescents living with HIV, including prevention of STIs and RTIs through providing information on the STIs and RTIs, screening, and treatment. But these HIV services have limited integration with the adolescent health programs because adolescents are treated either as the pediatric group or as the adult group. So the sensitive period in between of this, the transition phase is missing on both the sides. And therefore, the needs of adolescents living with HIV remain unmet in the existing healthcare system. NACP5 has also emphasized the sexual behavior assessment and adolescents counseling on STIs prevention, including cervical cancer and preventive strategies, but it is lacking at the health system level because there is a low awareness among the stakeholders about the prevention strategies, including HPV vaccine, and the major factor is parental unwillingness. Because HPV is associated with the STIs, it's a sexually transmitted infection, and talking about sex is a taboo in our country. So parents are really not willing to talk with their growing ward about the sexually transmitted infections, and they are also not encouraging the healthcare providers to talk with their wards regarding the STIs. With the increasing cases of cervical cancer, it is really important to understand the knowledge and beliefs about the cervical cancer and its prevention strategies, and also willingness of HPV vaccine among adolescents and young adults, particularly in the context of HIV in India. So with this background, the aim one of my study is to examine the association between HPV-related knowledge, awareness, and attitudes of adolescents and young adults living with HIV with preventive behaviors and willingness towards HPV vaccination. In this study, we have used mixed methods design, and for aim one, we used the cross-sectional survey design. We surveyed among adolescent girls and young adult females living with HIV between the age group of 15 to 24 years. Through the help of non-governmental organizations working with people living with HIV in and around Bangalore. The data was collected using the survey questionnaire, which was focused on socio-demographic characteristics, awareness about HIV status, and knowledge about the HPV and cervical cancer, including vaccine willingness. Aim 2 is the qualitative aim, in which we explored the parents and guardians and healthcare providers' knowledge, attitude, and perception about cervical cancer, its prevention, role of stigma and gender norms on acceptance and willingness towards HPV vaccination among this population, and to explore the strategies to integrate HPV vaccination within the existing HIV prevention program. Using the purposive sampling technique, we conducted in-depth interviews with parents and guardians of adolescent girls and young adult females living with HIV, and healthcare providers who are looking at the adolescent and young adults' reproductive health, HIV, and adolescent health issues. The interviews were conducted using the interview guide, which was focused on health issues of adolescent girls and young adult females in the context of HIV, knowledge of their HIV infection, and their status, and knowledge of HPV infection and cervical cancer, including prevention strategies, diagnosis, and treatment, and awareness about HPV vaccination and willingness towards the HPV vaccination. So for the survey, we screened 110 adolescent girls and young adult females living with HIV, and we recruited 102 participants. The mean age is 19 years. And we looked at the willingness towards HPV vaccine, and there is not a significant difference between the mean age in the willing and non-willing group. 87% of participants belong to the urban areas. 70% were having a family, but interestingly, only 16% were living with their family members. 61% were completed their senior secondary education, and 71% were students. The mean age at Minarke is 13 years, which is also same in both the group. We have also explored the factors associated with HPV willingness, which are including of the reproductive and sexual health behavior, knowledge about their HIV status, and knowledge about HPV and cervical cancer. 16% were having a boyfriend, and only 6% were ever engaged in the sexual relationships. 54% were experienced RHH symptoms, and which is also statistically significantly associated with the HPV vaccine willingness. 87% were aware of having HIV as a chronic illness, and only 6% heard of HPV. 18% know the name of cervical cancer, but they don't know that it is caused by the HPV infection. 8%, almost 8% perceived that they can get HPV, and this is because they are aware that they are living with HIV and they are prone to infections, and so that is their perceived risk that they can get the HPV infection also. In the cervical cancer knowledge score, the range was 0 to 21, and the mean mean score is 9.08 with 5.05 standard deviation. We tried to explore what are the reasons behind their willingness and not willingness for the HPV vaccine. 77% reported that they feel they are at risk of HPV infection and they can get the prevention from cervical cancer in future if they get the vaccine. 88% were not aware of HPV vaccine, and that's why they are not willing. They need more information on that. But 23% reported that parents will not allow for the HPV vaccination, and that's why they are not willing to get the vaccine. In the qualitative phase, we recently completed the qualitative data. So we are in the process of processing and analyzing the data. But the preliminary emerging themes from the qualitative data I'm going to present. The first theme is no access to adolescent reproductive and sexual health services. And this is because of the parenting culture in India. Parents are not they are not providing any independence to the adolescents that they can access the healthcare services by their own. So it is like the parents' right to know what is going on in their reproductive and sexual health life. So they cannot able to access in privacy the RSH services. This led to our second theme, that adolescent HIV population is ignored, though there are guidelines that their sexual behavior should be assessed and they need to provide a counseling on RSH. But since parents are not willing, so healthcare providers are ethically feel paralyzed not to give the information to the adolescent population. There are cultural and self-health perceptions. They thought, I am okay, I'm good, I'm not having any gynecological problem. So what is the need of going for the screening? So that's why there is a low screening of cervical cancer. And these are the responses which we recorded from the mothers of the adolescent girls. And if mothers are not going for the screening, they are not encouraging their girls also for the vaccination. There is a low, and this led to our next theme, low awareness about the HPV and HPV prevention. And the next theme is parents' unwillingness, because it is a major decision factor for the HPV vaccination for an adolescent. If parents are not educated, if parents are not willing, they are not, adolescent cannot get the vaccination. The next theme is attitude towards the HPV vaccine. The adolescent itself reported that cervical cancer will develop after 10 years or 20 years. So there is time, there is no need for the vaccination. And the another is I'm going to die. So there is, till the time cervical cancer will develop, I'll not be there. So what is the need of vaccination? So this shows that there is a lack in the counseling about the ART. And so there is a need to develop the faith among adolescents for the ART. So counseling gap should be filled. And this led to our next theme, bridging the gap approach, where we can use an integrated approach of combining the healthcare providers, parents, and adolescents to make them aware about the RSH issues and importance of HPV vaccine. So if we want to accomplish the global goal of eliminating cervical cancer, it's really important and need of this hour that HPV vaccination should be included in the India's national immunization program. Considering the association between the HIV, HPV, and cervical cancer, a focused and holistic approach to provide information on sexual and reproductive health to adolescents and provision of HPV vaccine to this population is required. There is a need to increase awareness about HPV infection, cervical cancer prevention strategies, and vaccine by educating the parents about the importance of HPV vaccination and also using an integrated approach of healthcare provider, parent, and adolescent and young adult living with HIV. Future research is required on feasibility studies to test the strategies such as mother-daughter dyad, which will help not only in uptaking the HPV vaccine, but it also help in uptaking the cervical cancer screening and its diagnosis and treatment, sexual risk behavior assessment of adolescents and young adults, and the age-specific need-based counseling guidelines are required. Training of healthcare providers, particularly the healthcare providers at HIV centers and ART centers, is required. There is need to sensitize them on the adolescent reproductive and sexual health issues, and there is a need of refresher trainings for them on the cervical cancer strategies, what are the available prevention strategies, and HPV vaccine, so that it would help in preventing the infections and uptaking the vaccination. So I would like to express my deepest gratitude to my mentors, Professor Maria Extrand at UCSF, Dr. Premlata, and Dr. Tony Raj at St. John's Research Institute. I would like to thank Fogarty International Center and National Cancer Institute, NIH, for funding this research study. I would like to thank UCGHI GloCal Health Fellowship Program, Dr. Cohen, Kimberly, and Julie for their constant support and guidance. Ms. Elsa, who is guiding me for my statistical analysis. A huge thanks to my study participants, because without them, I cannot be able to complete my study. The non-governmental organizations who helped me in recruiting the participants, not but the least my research team, Dr. Nafisa and Ms. Preeti, who helped me in data collection. Thank you.
Well, last but not least, our third GloCal Fellow, Dr. Deepa Srinivasan, who will be talking about a completely different population and problem, also urgently needed work with tribal populations. And she will be looking at a culturally sensitive risk reduction strategies for cardiovascular disease centered on optimal uptake of evidence-based treatments among patients with multimorbidity in a resource-constrained tribal setting. So that's a mouthful, but she will explain it all a lot more clearly to you. Come on, Deepa.
Thank you, Dr. Extrand. A very good morning to one and all present here.
Recording in progress.
I will be present, and Dr. Deepa, sorry. I'm Dr. Deepa Srinivasan, working as a faculty in the Division of Clinical Research at SJRI Bangalore. I'm here to present my GloCal study on culturally sensitive strategies focusing on CVD adherence among patients with multimorbidity and who belong to a tribal area. So my study is called the INEGRATE. With just a brief background on the tribes present in India, India homes more than 1/3 of the global tribal population, and almost 9% of the Indian population belong to different tribal groups. We have around 705 tribal groups identified, among which 75 are identified as 7 particularly vulnerable tribes by the government of India who are on the verge of extinction. The tribes are hugely diverse in the country with generally poor health condition, and they are multidimensionally affected because of an interplay of different factors. Now, with usually poor health condition, we are also facing the burden of NCDs among this population. There is a huge epidemiological transition that's happening. I'd just like to bring your focus on the data on the right side of the table. The first column is a data by the report of the Expert Committee on Tribal Health by the Ministry of Tribal Affairs, which shows prevalence of hypertension to be around 16 to 30%. Compared to the non-tribal population, it looks low. Similar to diabetes, which also is low among the tribal population compared to the non-tribal population. However, the most important finding is that the CVD related mortality among tribal population is much higher compared to the non-tribal population, which brings us to the important fact that there are two important challenges. One, probably access to medical care and medication adherence is poor. And the more important is that we are not adequately screening this population for CVD and its related risk factors, which brings us to our important finding that we really have to focus on NCDs among this population. There's also an important factor among the tribes of India, which is the intertribal inequities. That is, the North Indian tribes are more backward compared to the South Indian tribes in terms of basic needs, education, and their health status. We reviewed around 26 studies in literature. Search was done on all the 26 studies. Unfortunately or fortunately, we realized that all of them have just studied the prevalence of different risk factors associated with CVD, while none of them have studied on specifically CVD interventions or the presence of multimorbidity in this population. With all of this background, we wanted to look at the characteristics, treatment patterns, and medication adherence for CVD among patients who live with another chronic condition in a tribal setting. And eventually develop and refine strategies for CVD, which are both culturally sensitive and socioeconomically vulnerable to this community. However, for this presentation, we will only be focusing on my first objective, which is understanding of these factors. This is a map of India. Somewhere here on the top is New Delhi, and down south here is the place where we work. The first arrow is the place where we work, and the state is called Karnataka. And the next arrow points at the study setting, which is called Sitlingi. It's a tribal area in the southern part of the country in central Tamil Nadu. It's a 4-hour drive from the place where we stay. The right image is one of the hills, and the other two images are on the other side of the hills. So the Sitlingi is a valley between the two hills, and it's absolutely inhabited only by the tribals of this region. Majority of the tribes have moved from the North India to South India. So the dialect of this part of the country, this part of the state is a little different from the remaining part of the state. And I belong to the same state, so I kind of understand their language, and my mother tongue is the same. So for this study, we did a mixed method study. We did an exploratory sequential design. We initially started with a qualitative study to understand the context-specific barriers and facilitators for CVD adherence. We conducted around 25 in-depth interviews among all key stakeholders, from patients, primary caregivers, healthcare providers who include physicians, nurses, pharmacists, and their field workers. The interview guides were developed and refined using the consolidated framework for implementation research, and they were then translated into the local tribal language as well as the state language, because some of the participants did speak Tamil as well. We are planning to do a thematic content analysis, and the qualitative study was done for 4 months. Since I did all the 25 interviews, some of the preliminary emerging themes that I would like to focus, and which kind of gave us inputs on what quantitative measures we wanted to actually look at. So the first three barriers were more patient-related, which was poor knowledge on CVD and related risk factors, poor perceptions towards health, and very high pill burden was some of the very common emerging themes from the participant side. However, when we conducted the interviews, we realized that there is a national program for non-communicable disease. There is a state-level government program for NCDs again, and a local hospital there, which is providing an excellent healthcare provision for this community. So there are 3 programs which are providing medicines for the same problem, and it's causing a lot of confusion to the participants. Each participant is getting same medicine thrice, and it's going to create a lot of chaos in this community. However, there is a health worker-based care that is provided by the Tribal Health Initiative, which is a local hospital there. That's working very well, and we also noted a high prevalence of CKD in this community. However, it's a very preliminary finding, and we really want to focus on the epidemiology of this to conclude to this statement. We also observed that majority of the patients are not receiving evidence-based therapy, especially antiplatelets and statins are not provided to even with participants who have already established CVD. And there is a changing and family social structure, which participants perceive to be a low social support, and this indirectly is affecting their adherence. This is just a box of one of the participants' pill box, which shows kind of every possible combination of medications that they have, causing a lot of chaos. For the cross-sectional study, we wanted to understand characteristics, treatment patterns, and adherence among patients who are above 40 years. We sampled around 200 participants for the study, and the outcomes were the following. We used the socio-demography and multidimensional poverty index, which is used by the Niti Aayog, the government of India, to understand if the participants are deprived of their basic needs. We also used a current morbidity pattern and medication history designed by our team. We then used the multimorbidity treatment burden questionnaire, which is a validated tool to understand the burden of treatments that the participant is taking. Our main outcome measure, which is the medication adherence, was used by generalized medication adherence scale. We use the EQ-5D for quality of life and the brief illness perception questionnaire. We also used self-validated patient-reported barriers for medication adherence. Moving on to results, most of my participants were geriatric participants with a mean age of 64 to 9 plus or minus 9 years. Half of them were females and 80% were belonging to different tribal communities. 99% of them were living in the hills, while their ancestors and some family members were still living on their 99% were in the valleys and some of them were still living on the hills. More than 85% of the population were not formally educated, and majority of them were living on agriculture-based occupation. Although it did not earn any income for them, and they just managed their food needs. The median family income was just $24, just the pensions that the government is providing to this population. The most common medical conditions that were associated was hypertension, followed by diabetes. Established CKD and CVD were also common in this population. And the most common combinations we found was hypertension with diabetes, hypertension with chronic kidney disease. Majority of the population had to travel at least 14 kilometers to their first healthcare facility in the tribal hospital. And if they have to travel for a tertiary healthcare, they have to travel to 50 kilometers, which is around 35 miles away. Most of them were consuming around 4 to 5 pills per session per day, and which most of them would count it to 10 tablets per day. Only 12% reported of any adverse effects. And only 28% of the population were paying out of pocket for their expenditure. Most patients above 60 years were enrolled in the local healthcare system insurance, which kind of gave them free medications for all their diseases. However, 22% of them have experienced any distressed healthcare financing, and they are on current debts for their chronic illness. Unfortunately, only 2% of this whole population have been ever referred for any complications for diabetes and hypertension, which is a matter of focus. The most important outcome measure for us is the adherence, which is reported to be 78.5% having good adherence. But when we asked on any missed pills in the last 1 week, 60% have reported yes. And if you again see on CVD risk factor controls, only 37% of them have controlled risk factors, which brings us to the fact that there is a social desirability that we would have underestimated their adherence. The treatment burden was low here. We had 72% who said they had not much of a burden with their managing their illness, probably because they were only going to that local healthcare setup, and they had no other options to go to any other specialist for seeing any other conditions. However, there was a high threat for their perceptions towards chronic care illness. Presence of diabetes, those patients who reported that they were not able to follow a consistent routine, they got confused with their healthcare providers' instructions, high pill burden, use of alcohol, lack of family support, transport difficulties, high cost associated, and the presence of adverse effects, all of them attributed to poor medication adherence, which is statistically significant. We are also working on the regression analysis, but at this stage, I'm not presenting the regression analysis. To just conclude on my preliminary findings, it's my first study. It's the first study exploring CVD interventions in this population. Adherence to evidence-based medications is good, but we really want to look at uh, the control factors for CVD risk factor. Self-reported adherence measures were used in the study, so there is a risk of social disability. Sitlingi itself has a very good health system. It may not be the representative data on all the tribes of India, which puts us in focus that we really need to focus on other tribal groups in India. There are both cultural and health related barriers which needs to be addressed, and that will be done in our next steps. I would like to acknowledge all my mentors, my LMIC mentor from India, Dr. Dennis, my UCSF mentor, Dr. Ekstrand, and my trans mentor from the Public Health Foundation of India, Dr. Kavita Singh. My sincere gratitude to the UCSF team, Ms. Kimberly, and my DCRT team back in country. Thank you so much.
Or are there questions here in the audience? Okay.
Great presentations, thank you.
Thanks, Ritu. So I will start then, and I would like to start with Merlyn. You described a really important population that has been overlooked in terms of their mental health needs, but you also briefly mentioned the really long distances that you and your colleagues have to drive to get there. So I can imagine that's a challenge, but also that there are many other challenges that you didn't tell us about. Could you maybe address some of them here for our audience?
Thank you for that question. Yes, so travel was definitely a challenge for our team, but apart from that, there were challenges like the initial challenge was to get an okay or a go ahead from the plantation managers itself, because they were very reluctant, because tea has now suddenly come into focus. I mean, it has been in focus for its exploitative kind of work, but they were very reluctant that the focus on migrant workers would put them on the papers per se. So the getting the okay and go ahead from them was a challenge. And the second challenge was the language was a big issue, because the workers came from all parts of North India, and then we just knew Hindi, but Hindi was not sufficient because many of them were Assamese, and then they had Bengali speakers. So getting our team members who could speak the language to get across to them was a challenge. Though all of us knew South Indian languages, we were having difficulty with the language. Apart from that, I think the weather conditions, because we collected the data on field, so we had an extreme weather. Initially, when we started in January, it was raining there, unusual rains in the afternoon, so it had to stop data collection midway when it was raining. And then as we came towards March and April, it was extreme heat. And that was itself was a challenge for us. Yeah. So these are the three challenges I can remember. Thank you.
Thank you. Rochelle, I think there have been some questions submitted through the chat. Can you read them for us, or?
Certainly. For speaker number 1, I'm curious if the scales you used have been validated in similar communities in India, or if you had to modify them for use.
Yeah, so to assess for alcohol use disorder, depression and anxiety, I used very commonly used and validated scales, which were the audit, the PHQ-9 and GAD, and there are multiple studies upon it. And to assess for knowledge, as well as knowledge regarding mental illness and the barriers to health seeking, we did not have a validated scale. So we had to develop a scale, for which we went there and did a pilot where we had a set of questions, tested it out, and then based on the cultural context, we narrowed it down to the questions which we used.
Thank you. Were there any other questions submitted?
For the chat, this is just the one.
Okay, then I will continue with Dr. Deepa. This is really very important data that you have collected. What are your next steps?
Thank you for your question, Dr. Ekstrand. Since we have a few key findings, especially with related to our qualitative study, we would like to seriously analyze the qualitative data first, look into context-specific behavioral theories, and probably develop an intervention package using community engagement techniques for the next step. But parallelly, we also wanted to look into the CKD finding that we have found out. We would probably do a pilot community screening there to just verify if our data that we are reporting is right. So those two things will be our major steps. And we are also working on our the center, the division as such is working on a center for advanced research. So the findings from this study will be highly helpful for application of the next study. Yes.
Thank you. And finally, Dr. Archana, I know you had a lot of challenges because you were dealing not just with one stigmatized disease, but with two. Do you want to tell people about some of the additional challenges that you faced in doing this project?
Thank you, Professor Extrend. The first challenge was study initiation itself because working with the population living with HIV is really important, but we need to obtain the permission from the state government organizations under whom the ART centers and HIV centers comes. And so getting permissions from these state government organizations was really very challenging. And to get into the community, we need to obtain permissions from the community gatekeepers, like the NGOs who are working with the people living with HIV. But these NGOs are, because they are nurturing this population, so they are very protective towards this population, and they are not willing to allow any outsider to come and just talk with them and get the data. So it was very challenging to make them understand the importance of that study, and so that they can help me in getting the participants. The another challenge is we also need to look at the timings of the data collection, because these are the groups who are going to the schools and colleges. So there is an exam timing, there is the semester timing. So it was really very difficult to conduct the data collection at that timings. So we did in the evenings or on the weekends, whenever they are free. That time we go and just talk to them. We need to take their appointments first. And the third challenge is recruiting the parents, because parents are really not willing to participate in the study, and they're also not permitting their kids to participate in the study. So these are the major challenges.
Yes, well, it speaks very highly to your persistence that you got this done and got it done in a timely manner. So congratulations for that. I think, Rochelle, there is one last question on the chat, maybe. I saw something popping up. Maybe Deepalika?
Yes. Would you like me to go ahead and ask it,
Yeah,
Deepalika?
yes.
I can ask it. Okay, so for speaker number one, it's a critical first step to discover the mental health issues in this ignored population. And what next steps do you envision to address these issues in the migrant workers' lives? Medications, non-medical interventions, what do you think will work best and be most accessible and effective?
Thank you for that question. That's what we have also been thinking about. Now that we have identified that mental health is a problem, what do we do next? So we have tried certain approaches which do not involve the use of or the help of psychiatrists or psychologists, like using lay health counselors, lay counselors, or even peer educators to spread the word about it in different settings, not in the plantation. So we've used it in the garment and apparel manufacturing industries. So we are trying to look at such interventions which will be very cost effective and which will be culturally appropriate to be included in this setting as well. Maybe training a set of plantation workers in basic counseling, and also equipping the existing healthcare professionals, task sharing, task shifting, where they can be taught about mental health and how to quickly identify people with mental illness. These are the few steps which we're thinking about for future.
Thank you. I think that brings us to a close of the hour. Is that correct, Rochelle?
Correct. Yes. Thank you so much. to all of our speakers and to Dr. Ekstrand for chairing the session. Do you want to close us out, Dr. Ekstrand?
Yes, I think so. Thank you, everybody. And I think I speak for all three presenters when I say that they're going to be around for another 2-3 weeks. So if anyone wants to reach out to them personally, you can do so directly on their UCSF emails or contact me and I'll put you in touch. Thank you.